Y'all are ahead of us up there. You are. Okay.
Almost. Oh. Let's put it right here. Okay.
That works.
That works.
All right.
Okay. Good afternoon, everybody. Thank you for coming back. Here. And very pleased to introduce Norval Hickman, Program Officer of TRDRP. You're in Oakland, Berkeley? Oakland, okay. And Norval came down a couple of years ago for a drug addiction research day, and he's the guy who makes this all possible because he gives us the money. Although, I was going to say to him, well, we still haven't gotten our money yet, Norval.
I know.
Okay. So please. Okay. So Norval's going to be talking on California tobacco tax and smoking cessation, health disparities and smoking cessation.
All right.
Thank you, Norval.
Thank you, Theodore. And good afternoon, everyone. Hopefully you can hear me okay and also online. Just make sure I have this good. Yeah. So I'm a program officer. My role is to help shuttle research proposals through the review process, and if they're successful, oversee the work as it's conducted over time. And also things come up, especially in community-based research. So I've been with TRDRP for 7 years, a little over 7 years. I oversee the social and behavioral sciences portfolio. There are a lot of tobacco-related health disparity grants that come through my desk that I'm responsible for making sure that the work's done. There's meaningful findings for communities, and hopefully it gets disseminated out there. So today I'll be talking about the California tobacco tax. Person mentioned earlier, what's that $2 blip? That means it's more expensive to buy tobacco products. And also about cessation in regards to health disparities. So let's get into it. I have a lot of slides. Let's see. So once I hit this one, I think it should go. Okay. Just a little bit of overview. We're going to talk about the impact of the California tobacco taxes, disparities, and in particular working with diverse groups in the quit smoking process. Okay. A little bit about TRDRP for folks who don't know about us. We've been around for quite some time. First came about as a result of Proposition 99. The voters approved that back in 1988, 89. And then all that did back then was add a quarter state tax to each pack of cigarettes. And back then at that time, given how many people smoked in California, that was quite a bit of money. And that money funded not only TRDRP, but the state tobacco control program. You see ads, anti-tobacco ads that come from the state. It also gave money to the Department of Education for school-based tobacco prevention. Then in 2016, that November election, California voters approved Proposition 56. And that added an extra $2 tax to each pack of cigarettes with an equivalent tax apportioned to e-cigarettes and other tobacco products. So even Juul and Juul pods there's a tax that's applied to those, at least the pod and the e-juices as well that contain nicotine. So of those, and then the Prop 56, I put some language here, it expanded our purview. So it wasn't, it expanded it so now we can even fund research that looks into the causes, early detection, and effective treatment and care and prevention approaches and cures for all types of cancer, cardiovascular diseases, lung diseases, oral diseases, and of course tobacco-related diseases. And a big emphasis of Prop 56 is about health disparities and making a dent in tobacco-related health disparities. So,
is the tax on e-cigarettes include online, or is it just at retail?
So definitely retail. If it's online, and it's supposed to include online. Now the AG's office is involved in that, so they've been better at tightening up places that aren't collecting and sending the tax. But there's a lot of pressure on e-cigarette retailers about youth access. So, which is good, and Juul in particular. But any of these companies selling flavored tobacco products even online are subject to this tax. So there is diversion, but our revenue has increased more than we anticipated because some of the speculation is it's related to e-cigarette sales being higher than what we think. Yeah. So, okay. So when I talk about how much, what that tax did, Prop 56, that's the blue line. So if you look at the orange bars there, in the early 90s and stuff, we got a lot of grant applications. And then the money dipped, and Pete Wilson, in that big dip there you see in the mid-90s, he diverted the money to the general fund, and then that went to court, and then the court said, nope, you can't do that. So it came back to us, but the state gave it to us in increments. And then over time, the buying power of those funds declined. And 25 cents each pack of cigarettes, there was a tax added to other tobacco products, little cigars, cigarillos, but it was at a lower rate than that 25-cent tax. And TRDRP's budget was about 10-12 million, even up till 2016. And then we got this big bolus of money from Prop 56, and our budget ballooned up to 90.9 million. Just give you a little extra information here, just so you can see what our budget is like. So when you're dealing with state funds, you get a governor's January initial budget estimate, or forecast, I should say. That doesn't mean that's the money you're going to have, but as a state agency, you have to budget and plan your activities around that governor's budget in January, and then in May, you actually have to make adjustments, and then that gives you a sense of the actuals. And it used to be this number actually fluctuated. It could fluctuate by, 3-5 million, even more sometimes. So that's why we closely track it. And then even after the May revised governor's budget, there's a final July budget that has some additional estimates. And some of this is sales, and then the state kept keeping a little bit to make sure it doesn't dip too much precipitously. It's kind of complicated, but I just wanted to let you know in our the budget we're looking at right now that we're funding off of 18-19, that's about $63 million. So a pretty substantial level of funding for a state program. All our grant monies, the lion's share, all of Prop 56 money has to stay in the state. And the Prop 99 money, a limited amount of it can be used for out-of-state, like collaborations and buying tissue samples and, data sets from other places. All right. Our research priorities are quite extensive. We cover soup to nuts, so basic biomedical research to public health, disparities, cessation, policy research, toxicology, environmental sciences. If you're a California researcher or student and you're interested in tobacco research, you're eligible for these funds. So got to be a California resident or work, for a California organization. And I'm not going to go into great detail because this is on our website, trdrp.org. I should have put the URL there, but pretty easy to find. We have grant mechanisms that in a way parallel what the NIH grant mechanisms are, meaning that we have a full research project that tells you how long and how much per year for those grant mechanisms. A full research project is like an R01 equivalent for us. You have to have pilot data. Then we have a pilot data mechanism to get that pilot data, and that can be a 2-year project, as you can see there. Those are the direct costs, and institutions do get full indirects. On top of that, unless they're a UC campus, then their indirects are capped. And we brought back the new Investigator Award. That's for folks who are 5 years from completing their PhD or postdoc, and they're in a research scientist or faculty position, non-mentored. So this is not a K award. This is non-mentored, and to give people some extra funds to do tobacco-related research. And then we have 2 training awards, one for postdoctoral fellows that can be up to 3 years, and for predoctoral fellows, people enrolled in a full-time in a doctoral program working towards their PhD can apply for a predoc award. So that's like the NIH equivalent of an F31 for predoc or F32 for postdoc. Follow similarly, but we do deviate sometimes for California specificity and importance. In terms of funded research in the last cycle, given we had 90 million, and that was unusual because we had 5 quarters of revenue. We normally get 4 quarters from the state, but the tax went into effect April 1, 2017, so that's why we got 5 quarters. As you can see, we funded heavily in the social behavioral sciences, and that's primarily health disparities work. Actually, it all is health disparities work. So it's working with what we call priority populations, racial ethnic minorities, LGBTQ communities, people with mental illness, low income, rural issues. I can name more, but the groups that are using tobacco at very high rates and are most impacted by tobacco-related diseases. But you also see we fund heavily in cancer, which does include a lot of basic biomedical science, bench science, Neuroscience, oral diseases is new. Just gives you a little flavor there. And we've been having 2 cycles for 2 years, and we're in the middle of that second 2-year cycle phase. We used to only have 1 cycle a year. That means there are 2 opportunities to come in for a grant, and we actually have an open window up until February 7th where people can submit a letter of intent if you're interested in applying for one of those grant types that you saw before. You want to get your letter of intent in by February the 7th, 12 noon, hard deadline, and then the applications are due in March, I think March 14th, the full application. So letter of intent makes it so we can see that it's a tobacco-related project. There can be cannabis tobacco co-use, there can be alcohol, tobacco co-use, opiate-related issues and co-use, but there has to be a major tobacco emphasis in the research proposals at all, even if you're a pre-doctoral student. All right, so now I'm going to move into, and if you have questions about that, bring them up at the end. I do have a lot to go through, and we'll see how far we get. So we're getting to really some meat and potatoes about disparities. Some of these are not surprising to you. This is from the California Tobacco Facts and Figures. This is what the California Tobacco Control Program puts out in their reports. I don't have the booklet, but it's free online. I have a PDF. So you can see which groups are using tobacco at which rates, who are most impacted even by disease for tobacco-related diseases in California. And what you'll find is, in particular, if you look at, even though we have the second lowest smoking prevalence in the U.S. compared to other states, we still have a lot of African Americans smoking, in comparison to whites, if you see there, only surpassed by American Indians. But even though Asian Pacific Islanders are low, it depends which Asian ethnic groups you look at. So Filipino Americans have a higher tobacco use rate. You have to really disaggregate Asian ethnic groups, and if you can, Latino ethnic groups as well. And then, the other things, the other high rates of use do follow that line that we see with other substance use according to SES. So people of lower income, less education, living below the poverty line are smoking. Those are our smokers. And, of course, people with mental illness. The LGBT community also smokes at higher rates. The state smoking prevalence, if you cut across everyone, is about 11%, 10.3%. It fluctuates around there. So that gives you kind of a marker of we have groups that are smoking, even if they're small in number in the state, among those groups, they're smoking at very high rates. And that is concerning. That means our interventions, our prevention programs and treatments aren't reaching these folks. In terms of, this is SEER data, 2010 to 2014, just wanting to pull out the disparities that people in this room, I'm sure many of you are aware of, that people of color, in terms of incidence, new cases and mortality, for most of these, especially African Americans, we bear a greater brunt. Now, some ethnic groups have a lower prevalence, and there's been arguments that using whites as the comparison group is not always the best approach because they're increasingly not as healthy with cardiovascular disease and heart attacks and strokes increasing among white Americans, especially low-income folks. But this kind of lets you know where we are. And this is the kind of data that we always present at these presentations. So just want to give you that flavor. Cardiovascular-related U.S. death rates among adults 35 or older, CDC data, as you can see, deaths from heart attacks, much higher, among African Americans. Even in California, we're about what we see in the U.S., even if now a little bit worse. American Indians, Alaska Natives as well. You see the stroke risk with deaths related to stroke being very high, and coronary heart disease. So we're not doing well health-wise, and a lot of public health and clinicians know that tobacco plays a big role here. Heart disease accounts for 1 in 4 U.S. deaths. Coronary heart disease is responsible for 370,000 deaths per year. Of course, and you see this has been a trend or a pattern we've seen for a long time, some decades now, where Black men and Black women are dying more, are more impacted by their heart disease. And there are a lot of barriers and access things, social determinants that are feeding into this. But behavior change and focusing on cessation can really help get some of these this disparity down. Now let's go back to California, looking at lung cancers and cancers of the bronchus, bronchial area among adults 35 and older. As you can see, all those slopes are going down. That's great. That's what we want. But we see, even among African Americans, even if we've had this decline, there's still that disparity. And some people argue back and forth, it's controversial, will we ever close that gap? But, we might argue, we haven't made much progress among Latinos, that even though it was lower, it hasn't, it's kind of, it appears to have flatlined. And what other efforts can we do among Latino smokers who are still smoking? It might not be always the women, but we know among Latino men that there is a higher smoking prevalence and acceptability. And we can see, and it shows too that whites aren't doing so well either. So we got to think about when we present this data, sometimes it's better to present one ethnic group to another ethnic group over time. So see how African Americans are doing now compared to some years ago versus saying, the reference group are whites because they're not always at the lowest prevalence. So it doesn't tell the whole story. All right, so this it might be a little confusing, but I wanted to show you the adult cigarette smoking rate for California. But what we have here in the blue bar, the width of the bar tells you the number of smokers. So that's more like absolute value. That's because, we have certain groups that are represented in large numbers in the state. Whereas the number or links to the actual prevalence within that group. So if you look down, it might not be as surprising. American Indians, we have, a 24% rate, it says here in this collected sample, but very small number in the state. Among African Americans who are high school non-completers, it's a 40% smoking rate. So we know it gives us a sense of this is a group that is not getting touched, the materials aren't getting to them. People might be in alternative learning environments where our great anti-smoking campaigns aren't reaching them. But as a group that, in terms of all Californians, still, a smaller group. Doesn't mean that it's not important to focus on those groups, but we want, in terms of anti-tobacco efforts and cessation efforts, we do need a nuanced approach. You gotta really target the groups that are really impacted by this stuff. So rural folks, still 15%, and there's not a lot of research or activity focused in our rural areas, Central Valley areas. Okay. Menthol use is important, and I put this up here to kind of show some changes, and this cuts across all adult smokers. We know kids, majority of youth who start smoking cigarettes, it used to be they started with menthol. It's increasingly becoming they start with e-cigarettes, but menthol was a nice entry into tobacco use history because and I'll get into that because of what it does. It makes it easier to smoke. So in California, we have a high menthol prevalence rate, as you can see. If I get to it, I'll present some data showing that menthol makes it harder to quit. So that's why this is important in this at this level of presentation. We all know that tobacco use and disparities do not occur in a vacuum. It's important to consider where people live, work, issues of concentrated poverty, discrimination, access to health care, or culturally appropriate health care, I should say, all play a factor. So we want to use a framework, and this is one socioecological model that can encapsulate all the variety of issues that people are exposed to and experienced to that makes it challenging for them to quit, as well as maybe some resilience and protective factors that can make it easier or move that process of quitting along. So this it includes everything. We got to look at tobacco use across the life course. We got to look at the environment that people are in. We got to look at it's not just about letting people know they're going to die from it, but there's quality of life issues. If you don't die and you have a stroke or heart attack from your smoking, that has many years of detrimental effects. Okay. And we've heard the 5 A's a lot today, so I'm going to kind of gloss over that and say that there are other approaches which Dr. Eliza Tong covered well. She covered the Vidrine 2013 study saying, sometimes physicians aren't the best at the ask, advise, refer. So how do we encourage the ask, advise, connect? And she showed, some nice graphics on that. So I'm going to go past this. But the main line is, because this encapsulates the study, is it's important that that when you're connecting people, hopefully there's a proactive approach. So one, you have some buy-in in the clinical encounter at whatever level. It's not just a physician. It could be the medical assistant. It could be someone who's checking you, taking your vitals, who, you know, a nurse practitioner or assistant. That there is a plan after that the patient agrees to that is proactive. So they know, you know, you've created connection, and there's going to, shortly after that encounter, someone's going to reach out to them with some information. If they're ready for advice, you know, move forward with that. And that's really what we're getting at here, is a proactive approach does make sense. This study was conducted in Houston, Texas, and their smokers helpline is available 24/7, which I think is a benefit. You know, people might be getting stressed and doing things, you know, outside a window of business hours, and it's nice. I know ours is open in the evenings, but on the weekends, the hours are more limited, and it would be nice to see a little more, I think, coverage even on the helpline. And these are the results. It says the proactive approach increased the contact rate by 13-fold, which Eliza covered earlier. So I'm going to go past that. But we do know, so NRT for the general population does increase the chances of quitting. And I think it says here by 50 to 60%. And that's glossing across, you know, race, ethnicity, differences, and stressors, and all of that. This is a Cochrane review. And this is not just covering patch. This is patch, gum, lozenge, you know, all the evidence forms of nicotine replacement therapy. We're not talking about varenicline varenicline or bupropion. You know, we're talking about if patients do stick with it, that they do tend to quit. However, you have to be really important in how you educate folks on how to use the patch or the gum, right? You know, you don't chew it like chewing gum. You chew a little bit, you park it. You let the nicotine go through the gums. That's how you get the nicotine. Through the stomach, it's a longer pathway, and you're not going to get that nicotine or the withdrawal relief as quickly. So as a provider, you really, you know, need to have a little space to say, I'm going to give this to you, but how do you use it, right? And with the patch, I advise, you know, people should take it off at night. A lot of patients have vivid dreams or nightmares, and in particular, African American smokers, they have a few really bad nights, and they've had the patch on. They don't want to go back to it, so you want to head that off early before you troubleshoot some of these adverse events. I consider them adverse events, even though they're on the boxes. These are side effects. So keep that in mind. You know, as a provider, being comfortable having that conversation, and as they ask you questions about, when should I not use it? That you're okay with saying, don't use it in this way, use it in that way. Quit attempts by race, ethnicity. So quitting is hard. You know, most people try first time. You know, quit attempts is considered a 24-hour period of not smoking tobacco. It's hard. People have to try multiple times. And we used to say 7 times. Now some data shows it might take up to 20 times for some people. Start, stop, varying levels of time. And I just want to show some racial ethnic differences in quit attempts. And, you know, in particular, you know, we see on the left here, you know, that there are a lot of other minority groups that have a harder time, you know, getting those quit attempts under their belt. Because every quit attempt is a move towards abstinence of not smoking. We know when someone quits, even if they relapse the next time, they have a better chance of not relapsing again, or a longer duration of not smoking. So we have evidence to show that, research-wise. And I put the blurb on the right side to show that there is some evidence that, you know, menthol smoking is associated with a harder time quitting, and that is across race ethnicity, even for white menthol smokers. And of African American smokers, over 80% smoke menthol cigarettes or flavored cigarillos, if that's their choice. And we have still not addressed the high rate of smoking, and you see a lot of quit attempts among multiracial folks who are experiencing, you know, I think even some unique stressors that have not been addressed in some culturally sensitive tobacco treatment materials. So now I'm going to get into some studies. Yeah, it came up pretty good. I'm going to get into some studies that kind of look at tobacco cessation program, interventions, treatments, kind of leaning on the randomized controlled trials. You know, we consider that the gold standard in research, but you'll see some quasi-experimental stuff in here too, and see what do we have, what do we show for different racial ethnic groups at least. So colleague, friend, Monica Webb Cooper, 2009, published this results from a randomized trial And we know that in terms of using a culturally specific booklet or a standard booklet, that's for a general population, and looking at dependence variables, seeing what's going on, readiness to quit, and main findings, the greater readiness to quit and more 24-hour quit attempts were found in the standard condition. This is for African American smokers. No differences were found in abstinence rates. And actually what she found is that African Americans responded positively to the culturally tailored materials. This was Pathways to Freedom. The CDC developed this. It's a booklet, and there's a DVD. It needs to be updated. It's still in DVD form. That is about how, African American specific smoking cessation materials, self-help materials. And even though African Americans say they like that, the folks who read the standard material were more likely to act on the information on that. And, I don't know what's going on with that, but, sometimes we think cultural specificity is needed. And sometimes it is, I think, to get the attention of the person, but we might need something else to kind of get them still engaged in the quit smoking process in addition to it. And that's how I've used it in clinical trials. I'll use the evidence-based Cadillac cessation treatment, and then I'll have the Pathways to Freedom or things about menthol and more culturally sensitive stuff tagged onto it. King et al., this study of urban low to middle income African Americans, really looked at feasibility, acceptability, early outcome indicators. It was an intensive six-session group program delivered in the community and a one-month supply of nicotine patches. The intent to treat model, we do that because we lose some people, so we don't want to have ourselves off when we look at our data. The intent to treat showed that 34% quit smoking. That was biochemically verified. That means they took their blood or urine or saliva to confirm they did quit smoking at 1 month after their quit date. But then, as we've seen a lot of these treatment trials, the quit rate, the abstinence rate declined at 3 months to 22% and 18% at 6 months. There was no comparison sample or control group. This was a pilot, and this is kind of how research is done. You got to see how are people responding first, and if it looks good, you go for the next bigger grant. Okay. Matthews et al., Alicia Matthews up in Chicago, did a quasi-experimental study looking at culturally targeted group counseling versus standard treatment. And this was really, again, focused on acceptability, feasibility, and early outcomes. The culturally tailored group in this one had high levels of feasibility, acceptability, better adherence to nicotine replacement therapy. So they liked the culturally sensitive materials on this one. And using the intent to treat analysis, at the end of treatment, biochemically confirmed quit rates were directionally better for the culturally targeted group at 63% versus the standard group. So, it looks like there might be something there. At 3-month follow-up, this is carbon monoxide verified quit rate. So you blow into a little thing that says, have you smoked in a certain amount of time or not? It does pick up cannabis smoking, so might not be as sensitive these days. But at 3-month follow-up, the CO verified quit rate remained directionally higher for that culturally tailored group versus standard group. But at 6 months, interestingly, quit rates were similar between the groups. So there is a thing of how do you keep this stuff fresh in people's minds? And even if they have quit a while, there are probably some other social pressures, stressors, or other things. I mean, nicotine really, some people think that it's helping them, or it's really hard to quit. It's an addictive substance. We got to keep that in mind, even if you have those resources and some skills up front. So again, limitation of this project, small sample size, low power, and generalizability. Again, it was a pilot. They didn't have many men in it, and I guess there weren't culturally relevant messages that address minority stress, discrimination, and I think that's increasingly getting more important. So it's not just how do you deal with the nicotine withdrawal, but how do you deal with some of the stressors that's contributing to it. In particular for African Americans, that's what the study was conducted on. I think how to deal with microaggressions and stressful discrimination would be very, very helpful in this. And then the final study focused on African Americans by Anita Fernander, pilot study on Breathe Free for Women. It had 6 cohorts in 42, did 9 group sessions over 4 weeks. Primary objective of the pilot study was to examine the end of treatment quit rates, and secondary objectives sought to obtain feedback from African American participants on acceptability and interventions of the intervention in the population. So they want to see if people like it, right? That's what this feasibility, acceptability stuff is about. Do you like this kind of program? Do you think other African American smokers might benefit from it? Participants' feedback indicated that this program intervention offers a highly promising model for enhanced tailoring by incorporating socio-culturally relevant methods, materials, and content. And the end of treatment rate was 19%. The data revealed an average attendance rate of 70%, which is really good, with an end of study retention rate of 71%. So I would think in this study, the culturally tailored part got people to come back to those groups. You got to have it so it talks to people and resonates with them. Some limitations there, you can see specific interventions within each session were not endorsed at high levels of satisfaction in the participant group. Small sample size, 19% end of treatment cessation rate is not conclusive due to the unavailability of long-term follow-up abstinence rate. So they weren't able to contact people after the study and really see how they did later. It was self-reported cessation, so we don't have that nice biochemical verification as in the other studies. And the rate is in response to a standard intervention that, while appropriate for female smokers in general, lacks social cultural relevance for African American female smokers. So there was some comments about that, making it more tailored to African American women. And now let's look at a few interventions for American Indians, Alaska Natives. Joanne De Silva, 2011, published this study, results from this project. And the sample, 92% lived on a reservation. I believe it's in Minnesota. It's a quasi-experimental study. Authors describe it as a single group study focused on culturally specific individual or group counseling, 4 sessions, and choice of nicotine replacement therapy, varenicline and or bupropion. 7-day point prevalence abstinence, as if they haven't smoked in the past 7 days from when that question was asked, was about 22% at the end of treatment. Average of 2 quit attempts, which is good. That's promising. Decreased daily smoking rate. People are trying to cut down, and you'll see that with people. They're trying to limit the number of cigarettes per day, and delayed time to first cigarette smoking. 67% utilize some form of pharmacotherapy. This is promising. In that we can get some folks, if we can get folks to delay that time, that's a big proxy measure of nicotine dependence. So if you're getting up, you're smoking that cigarette right out the door, that tells you how dependent someone is. So you got to have something replacing that nicotine if you want them to have any success of getting distance from smoking. So we want to give them, we got to give something if you take something away, or if they're doing that themselves, they need something to replace that. This was a convenience sample, no control group, and self-reported smoking status. So people might try to sound good by saying they quit, and they didn't. But 22% is some indication there's probably some honesty there. They did have a high attrition, and the findings were not generalizable based on how the study was designed. Troy published another study, and this looked at Native Americans in rural areas or reservations. This was a randomized controlled trial of culturally tailored All Nations Breathe of Life program materials or non-tailored current best practices. And they use cotinine verified 7-day point prevalence, which is cotinine is a metabolite that you can detect in urine. They'll tell you a longer estimate, a time period when someone has not smoked than the carbon monoxide breath one. The point prevalence abstinence at 12 weeks was at about 28% in that culturally tailored group and 17% in the best practices group. So that tells us something about how this intervention spoke to folks. 6-month intent to treat point prevalence quit rate between the groups was a little bit lower, 20% and 12%. So they lost some folks, had to account for that down the road, I'm sure. And none of the cotinine verified results were statistically significant. So the biological measures weren't necessarily showing that gap, that distance. There's concern, possible bias in reporting since none of the cotinine verified data showed significance, significant loss to follow-up, and lower than expected salivary collection rates. So they were collecting saliva samples. And getting those samples, and working in rural areas, when I work with researchers doing this work, can be quite a challenge. So, what measures you're taking and how you collect them. Another study on Alaska natives by Prochaska, just give you a little flavor of a variety of different areas and projects. This was a randomized control trial, 2 intervention arms, one group tobacco and physical activity, another group medication adherence and a heart-healthy Alaska native diet. All participants received motivational interviewing, that's what that should say, stage-tailored, meaning according to their readiness to quit. Even if they don't want to quit, they got some intervention. If they wanted to receive it, we're open to it. Telemedicine delivered counseling sessions at 3, 6, and 12 months, 300 folks. Study is ongoing, but primary hypothesis is that the group 1 will significantly outperform group 2, and 18 months follow-up in tobacco abstinence and secondary increase in physical activity. So we hope if people are a little more physically active, it is helpful in the quit smoking process, so that's what they're testing out. Study focused in a single region in Alaska, and smokers without hypertension or hypercholesterolemia are excluded. Non-daily and light smokers were also excluded in this one. So that's an ongoing one. We just want to let you know, some of the culturally tailored cessation work going on there. Now move on, and there are some additional studies I could cover, but I wanted, in the interest of time, I wanted to kind of give you, some range of projects with different groups. Focus on tobacco treatments, focus on Asian American ethnic groups and Pacific Islander groups. I'm going to start with a study by Shuhong Zhu, published, he's running the Smokers Helpline that we've been talking about down in San Diego. And this data is on Chinese, Korean, and Vietnamese Americans. Culturally tailored counseling protocol was developed in English and translated into Chinese, Korean, and Vietnamese. It's a randomized clinical trial of culturally tailored quit-line counseling, 6 sessions versus self-help materials sent to folks. Primary outcome was 6-month prolonged abstinence. And the quit-line counseling led to significantly greater smoking cessation at 4 and 7 months compared to self-help. Intent to treat analysis showed counseling increased 6-month prolonged abstinence among all smokers compared with self-help. Counseling versus self-help, so you see the 16.4% versus 8%, and the analysis for that. There was no tailoring by ethnic subgroup, no non-tailored language congruent condition, and is by self-report. But this is promising. Even if that number seems low on population level impact, that's major. If we can get people to call the quit line, engage with it, there is some benefit from it. So, and I'm kind of giving you the sense that culturally tailored interventions, yes, are useful and helpful, but they're not necessarily the key or the magic that can create the behavior change, is what I'm also, sometimes people want to submit grants like, I have this relationship with the Cambodian American community, we just need to get something for Cambodian Americans. It's like, well, yeah, but you could also do something else too while you get something that really speaks to people in the language that they understand. Go through this one. This study on Chinese Americans it was a randomized sample of culturally and linguistically sensitive smoking intervention, 4 individualized motivational interviewing sessions and NRT versus control. The control group had 4 general health education sessions, self-help materials, and NRT. Abstinence rates at 3 and 6 months were really promising. At that 66% rate, and were approximately equivalent, and were nearly double in the intervention group, and significantly different from those of the control group at about half, at 30%. I think this was a biochemically verified quit rate of 6 months in the intervention group was 67% versus 32% in the control. This was a mostly male sample, and I think this study in particular was more targeting Chinese American men who smoke, given the rates among Chinese American men. But the findings may not be generalizable to all Chinese American smokers with various SES statuses. Longer follow-up period of a year, 1 year may help prevent relapse. 2 more studies, both published by Kim, focused on, Kim et al., I should say, focused on Korean American immigrants. First one, RCT of culturally tailored cognitive behavioral therapy, another evidence-based approach for behavior change. This one was focused on smoking cessation for 8 sessions versus medication management and brief counseling of 8 sessions. Both groups received nicotine patches. Biochemically verified 12-month abstinence was significantly greater for the culturally tailored group, 38%, versus the medication management group. And limitation here, it was a small sample, unmatched intervention intensity. So again, it needs a little deeper dive there. And the second study was a one-arm study of telephone counseling, kind of getting to what the quit line can do, plus nicotine patches. Looked at 7-day abstinence, 3-month prolonged abstinence by self-report, but corroborated by a family member, which research does show that when you get corroboration by someone else, a family member, a friend, that they're honest, they'll tell you whether it's quit or not. And so you can use that if you can't get the biochemical verification. At 3-month follow-up, 45% reported 7-day abstinence, and 42% were abstinent at 3 months, so prolonged abstinence during that time. Again, small sample. This was a pilot, so we didn't have a control group in there. And a few studies focused on Latino ethnic groups. David Wetter published in 2007, I think this is from Houston, Texas study. Spanish-speaking sample, they termed very low SES, so probably below the poverty line substantially, and 90% immigrants. This was a 2-group randomized controlled trial of a telephone-based versus standard counseling. And standard counseling, I think, was 1 call plus self-help materials or enhanced counseling. So the treatment group got enhanced counseling, which is that 1 call plus 3 more proactive calls, again, reaching out to someone, and looked at abstinence at 5 and 12-week assessments. Unadjusted effects of that enhanced counseling on abstinence only approached significant after controlling for demographic and tobacco-related variables, probably dependence and some SES factors. Self-reported abstinence in the enhanced counseling is at 20% at 5 weeks, 27% at week 12, and you see the standard group was lower, but did increase later, which is interesting. Short-term abstinence here as a limitation. We really like to see how people are doing further out, up to a year after an intervention, and reliance on self-reported cessation. And they did report they were mostly Mexican participants, either from Mexico or Mexican influence. Okay, and I think this might be one of the final ones focused on Latinos. I'll see. This one focused on Latino Americans from a variety of backgrounds, smokers receiving NRT in U.S.-Mexico border clinics in El Paso County. And they did a baseline questionnaire and 2 follow-up telephone surveys based on what people were smoking on the questionnaire, 8 to 12 weeks and 6 months. Medication use at baseline, just to see who was using what. 82% did use patch, about 50% lozenge, 29% gum, and 24% bupropion. And combination therapy was permitted. That's approved by FDA. So you can use multiple of these. You can have a patch on, gum, if you need lozenge, gum, don't hold back. Give people the nicotine they need to hold back the withdrawal. At 8 to 12 weeks, nearly 2/3 of patients were quit, and 44% remained quit at 6 months. It's very promising there. But people like that kind of, you give them education about the different products and you allow some space to explore and see what works for them, and you're not punitive or there's not a barrier. You get this kind of stuff where they're like, okay, well, I'll try it. And you're like, okay, what adverse events? Okay, now I'm trying it, oh, no, now I want to try this other one. Let them explore, because certain products in certain quit smoking processes work better for, certain people. That's the tailoring. We have guidelines, but we got to really work with individuals, and that's what makes the difference. Limitation of this study: no control group, small sample, reliance on self-report, and limited geographic location. So kind of focus on one area, but still important population. Oh, I do have 2 more focused on Latinos. One by Ricardo Munoz, psychologist, researcher up in the Bay Area. He worked a lot out of San Francisco General Hospital, and this was, I believe, this study was born out of. Focused on English and Spanish-speaking Latino Americans. There's a 10-year proof of concept smoking cessation research program evaluating the reach of online health interventions delivering smoking cessation education throughout the Americas. So it's not just U.S.-based, because it was web-based. Combined data from 4 studies, self-reported 7-day point prevalence abstinence, online self-help, automated intervention studies. So that's what they call it. It's a website that kind of tailors to where you are with readiness to quit and what kind of information you want to hear, little motivational interviewing embedded, all that good stuff. Main findings: overall observed quit rates for English speakers was 38%, and for Spanish speakers 37%. That's what we want to see. Quit rates in which participants with missing data were considered to be smoking, because we do have to deal with attrition, were 11% and 10%. So that attrition is a big thing. We want to hold our samples, hold them in our studies. Limitation, individuals reporting lower levels of education were less likely to engage in the website, so there might be some, not just language issues, but literacy issues that we have to consider. And in the work I've done with folks of, with limited literacy, they don't necessarily tell you. You kind of need to walk them through some information and see, be gentle in how you see it, if they can understand it or read it on their own, because they might not want to tell you they can't read. But they won't have their glasses. You'll know it'll be kind of hard for them to see it. Rodriguez, the last study, his study published in 2015, self-help interventions, two culturally, so it's cultural specificity, cultural specific or standard, times receipt of preferred language materials, preferred or less preferred between subjects experiment, all focus on smoking cessation as a secondary outcome. So really trying to see how people respond to the cultural specificity or not. Self-reported cessation was greater among participants who received a culturally specific intervention and materials in their preferred language. It did have a short follow-up, only 2 weeks, and is a standalone written materials, and they relied on self-reported cessation. But the tailoring, it does. It's what you need to do. Oh, and I did include a few studies that focus on the LGBTQ community. Alicia Matthews published this paper focused on lesbian, gay, bisexual, and transgender individuals. A descriptive study examined the benefits of community-based, culturally tailored cessation treatment programs for LGBT smokers, group-based. Freedom from smoking was used, plus tailoring to the community. And they looked at self-reported 7-day PPA as well. Some received NRT, and the groups ran between 2006 to 2008. And their analysis, intent to treat, revealed a self-reported quit rate around 32% at post-treatment. Overall quit rates were in the expected range for community-based smoking cessation treatments and ranged from 23 to 39% at the end of treatment. Session attendance and NRT use was associated with greater odds of cessation. So getting folks engaged, get them to come back. Only 42% completed treatment, and so that is a limitation, serious one, and it relied on self-reported smoking, no control group. Covey et al., I know it's a slightly older study, but still important, focusing on men, gay, bisexual men compared to heterosexual men. Aim of the study was to examine abstinence rates among gay men using a non-specific therapeutic approach, so a little more open approach. And smokers received 8 weeks of open label treatment. Everyone knew what they were using. With nicotine patch, bupropion, and counseling, biochemically verified abstinence at multiple time points during the study. The first 2 weeks after the quit date, abstinence rates were way high. Were higher among the gay bisexual group. I think it was at 89%, but it was also high among the heterosexual group at 82%. Then week 2, we see 77%, heterosexual group 68%. Abstinence rates actually converged, becoming nearly identical at the end of treatment, week 8. With gay bisexual men quit rates 59% versus 57%. And this just has with the analyses that were used. I didn't include the interaction effect there over time, but no data in this one, a limitation, no data explaining why gay bisexual participants showed a greater tendency to smoke again after week 2. And there was some assumption or speculation that it might be because it was a non-specific treatment, that it might have been people came in with that motivation, but maybe the non-specificity wasn't as helpful with, actually the quitting smoking process. In terms of a few other studies here, focus on LGBT individuals of various backgrounds, 7-session study, 6-week group education and support intervention tailored for LGBT smokers. Manual includes all of the freedom from smoking materials plus additional readings on smoking in LGBT communities. Intent to treat showed 59% quit rate at end of treatment. Most conservative one, that means you're going to see the people you lost for smokers, put it at 53% quit rate at 1 month, 36% quit rate at 3 months, and 36% quit rate at 6 months. Latinos and whites were more likely to quit versus other ethnicities, which is interesting. This one did suffer from high attrition. Matthews published one just last year, and it showed that it was a prospective randomized design longitudinal study was used to evaluate the added benefits of an LGBT culturally targeted courage to quit versus standard intervention. So 6 group sessions, NRT was, and then the main outcome was abstinence. Overall quit rates you see there start off high, 31, 32%, and then go down to 22%, and no differences between conditions. So, thank you. So it's helpful in these to, as you see these studies, sometimes when they have people set a quit date, you see this pattern. I'm going to say this now because I'm kind of starting to run out of time. You see this pattern where fewer people are quit over time, month, 3 months, 6 months, 10 months. The work I used to do, clinical trials, I would recruit people who were at all stages of readiness to quit, even if they didn't want to quit, but they were open to the intervention materials. And what you see there is when you do a 1 month, 3 month, 6 month, you have a smaller number of people who quit, and it expands over time. So you have more people quit over time because they're engaging with you at the 6 month counseling, NRT, what have you session, and you're kind of getting those seeds of motivation in there. So you will see more quit attempts, more quitting. The other model, start with quit today, you're going to see the opposite, and you've seen that pattern across these studies. So just wanted to give you all. If you're going to do tobacco cessation work with priority groups, including people of color, LGBTQ, people with mental illness even, you want to consider menthol. And that's the menthol plant right there. I'm just going to say a little bit about menthol. It masks the harshness of smoking. It gives you that throat grab, but it's a cooling sensation. You don't get the throat grab that you do from non-menthol. So menthol smokers tend to hold the smoke more deeply, longer, and they actually are getting more toxins. So that's why we call it the ultimate candy flavoring, and it really helps, not just the nicotine, but all the other toxins go down easier, greater cell permeability, all that stuff. And who smokes menthol? Over 80% of African American smokers are menthol smokers, but also Hawaiians and Pacific Islanders smoke at high rates. Filipinos in particular smoke menthol at high rates. Other groups a little bit lower. Puerto Ricans also smoke menthol at high rates. We do think because menthol reduces the irritation, thus increasing the amount of smoke that's inhaled, allowing it to go deeper, that it means greater nicotine intake, and the tobacco industry makes sure menthol cigarettes have more nicotine than non-menthol. And it's a flavor, like candy flavors. All other those are banned, cigarettes at least. So we think that this really makes this more addictive and harder to quit for people of color in particular. And if you look, menthol smokers try more quit attempts, as I showed earlier. They're trying harder and they're being less successful. So there's some specific tailoring, not just around African American culture or whatever culture you're working with, but really around what menthol is doing and having materials so people understand the added harms from menthol. We look at all the deaths. This is from the Pathways to Freedom booklet from the CDC. And this number has gone down for African American smoking-related deaths. It's down to 43,000, but it's still above 40. All of the deaths from homicides, car crashes, police brutality, HIV/AIDS, still, if you add them together, it won't come to the number of what tobacco-related diseases are doing to our community. And, people have video cameras and they're getting all this attention, and it's wrong. Police should not do what they do, but we lose sight of what is also killing our communities, and people are killing themselves. I feel like I should probably leave there because I want to get into the mental health stuff. That'll be for another day. So. Yes. You want me to?
No, because we're recording it.
Right.
Very nice talk. I have a quick question. Our group here at CDU is working on the detrimental effects of nicotine, including that delivered through electronic nicotine delivery system and high-fat diets on real organs, particularly liver, adipose tissue, muscle. Unfortunately, when we submitted our grants on liver or fatty liver disease were reviewed by cardiovascular study.
Oh, by in our study?
Yes,
oh.
Yeah. So what should we do?
You need to talk to that program officer and say have it reviewed elsewhere. No, I mean, if you submit in your letter of intent, what I do, because I'm in the social behavioral side, I would talk to the program officer, and you need to state the case. You need to, if you're going to resubmit this, you need to talk to, you said it was reviewed in cardiovascular.
Yeah.
And you wanted it reviewed in which one?
It's related to liver toxicity
Would it be environmental, like it wouldn't be the toxicology one, I think it's Yeah, I think that's part of the issue.
Because you'll be listening from Dr. Freeman in the next talk. So
Yeah.
This is really very important. But the study section seems to be
Yeah.
by some other experts.
Yeah. If I catch it in your next talk, where it might go, but some of that science is above my head, so I still would say talk to the program officer, that oversaw the study section. It might be Jenny Delaney, I'm thinking.
Yeah, she's the
Jenny Delaney? Yeah. It's talk with her because I think you're right. You might need it reviewed in one section with some expertise from another area. That's what I do when I have those. Yeah.
And so at this next cycle in February, you're only taking resubmissions except for postdoc.
Yeah. So resubmissions for faculty, postdocs, pre-docs can submit new ones. So yeah, that's for the one I said February 7th letter of intent deadline. Yeah.
And then there'll be a spring summer one, you think? Or?
I don't know yet. Yeah, because our money is going down, but then with e-cigarette sales, it kind of goes up. So I don't know what we're going to do next year.
Other questions, please? Do you think there's a genetic difference why menthol is used by African Americans, or do you think it was a marketing issue primarily? Or?
Yeah, that's what we're going to get into. It's all marketing. So in the 60s in particular, some in the 70s, the tobacco industry marketed heavily in black communities, and they would sponsor cool jazz festivals. They were all up in Ebony and Jet and Essence, black, magazines. And I remember hearing my grandfather used to smoke Lucky Strikes in the 50s, and then somewhere around the late 60s, he switched to a menthol brand, right? And we saw this wave happen, and they would go. Unfortunately, the tobacco industry has a close relationship in the black community. They used to hire some of the first black managers and supervisors and directors to work for the tobacco industry. They gave a lot of money to the NAACP and Urban League. So when there were laws and policies about menthol or tobacco, the stance from those organizations was no, no, no. Al Sharpton's funded by R.J. Reynolds Tobacco Company. He's going around talking about how banning menthol is going to lead to the criminalization of black men, and there's no evidence to support that. He's calling on the Michael Brown case, the Gardner case in New York, and how tobacco played a role there. So it's we have a particularly unique relationship with tobacco, but because the way things have been going status quo, I showed you that graph. Our folks are dying, and menthol tobacco products are cheaper in black communities. They do that by design. They make it cheaper in our communities to buy it, especially around schools in particular. And we funded a study. I have hard data to show that. So it's a marketing thing. That's what it is.
Have you seen menthol-flavored e-cigarettes be also more widely used among African Americans? There's not enough data on that.
Not yet. There's not enough data, and I'm not seeing the data that black African Americans are uptaking e-cigarettes. But people of color, it seems like in terms of the e-cigarette stuff, the tobacco industry is still going to have combustible tobacco in our communities, especially our poorer communities. Maybe there'll be, an e-cigarette that pops in here or there, but that's not really where the marketing effort is going. So the money is seen not in the communities we work in for that, not yet, at least. It might change, though.
Hey, how you doing? I'm David.
Nice to meet you.
I'm a research associate at Dr. Freeman.
Diversity supplement.
Oh, good.
So as a young researcher and aspiring physician, I just want to ask you, one, is there more efforts going on to provide more funding to be able to disseminate some of the information about the in those particularly vulnerable communities? And then also, for me, as I continue on my career path, what advice would you have for me to, be able to more widespreadly, be more widespread in my efforts to combat disparities?
Right. Those are good questions. So dissemination-wise, Prop 56, there's money available to disseminate this stuff. Now, the Tobacco Control Program does have some focused work on what they call priority populations. So they have coordinating centers that they funded, where if you're working in a Black community and you need some assistance with some tailored or what do you do around tobacco, you contact that coordinating center. So they're funded. And they have one for African Americans, Latino, Hispanics, Asian Americans. There's one focus on low-income folks, LGBT. I think there's one focus on Asian Americans as well. So that's, that's through that funnel. But a lot of times it might be like a county health person doing tobacco program or something like that, anti-tobacco stuff. I think a clinician, as you're seeing patients, you could go to that. Pathways to Freedom, if you want to give that to your patients, you can get that free from the CDC. I just went to a website, had a whole bunch ordered to me. It didn't cost a thing. And then I, do give that to some smokers who are African American. I actually created some of my own stuff too when I was doing clinical trials work. But I think engaging in conversation around people about this, like I don't say quit smoking. Like, what is your relationship with smoking? What does it mean to you? Having those good open-ended questions. I mean, actually, on the lift ride over, there was a young Black guy who was talking about his girlfriend smoking menthol, and it's a teachable moment. So I used that as a way to how, some suggestions of how he could engage with her, because she gets a little irritable about when he talks about it, but how to kind of soften it up so that he can talk with her about it. And then some information about the quit line and resources and what the past. So I'm doing that on my way here. I do this all the time. So, if you're open, enough, you can engage in that conversation. That's how we get stuff out in our communities. And if it's coming from you, it's going to mean something, right? Like, so you first get that kind of connection, see where they are, and then give the information. I don't start off with, these are the health issues it causes. I'm like, what is it doing for you? And not.
And I'll give a plug for our next next conference is going to be in July. Remember the exact date, Norma? July 12th. It's going to be on a dissemination conference. So really this one targeted to providers, researchers. That one's going to really target to community members and getting the word out. Okay. Yes, Norma.
Are you knowledgeable of any discussion regarding collaboration with and funding efforts to do cessation in the prison?
Ooh.
That's where a lot of our fellows are when they come out.
Yeah.
They're already DC.
Okay, so I used to, in my trial, a lot of my folks would go through the justice system and get incarcerated over the course of the trial. By the time I got IRB approval, my study was done. The follow-up was done. Now, some prisons do let you do telehealth or counseling over the phone. So, but I don't know of a collaborative project. I think that is needed. I mean, you need someone who has done research in prison systems, even if it's not tobacco, and then someone who has a tobacco expertise kind of to work. I mean, that would be the best. But yeah, and then do you start on one prison or a couple? You might want to start small on one because there's not much out in the tobacco world. That's like very minimal kind of work done.
So that kind of work would fit into one of the initial buckets.
Yeah, that would work. Yeah, especially if it's cessation, prevention, and cessation.